Sudden death from the cardiomyopathies. There is a heterogeneous group of disease of myocardium associated with the cardiac dysfunction known as the cardiomyopathies, which, though of mixed and often uncertain etiology, have sufficient in common pathology to merit a specific identity, as they account for the second largest number of sudden death after coronary artery disease. About 10 to 15% of all sudden death of cardiac origin, they are briefly described here. Though specialized text and papers on cardiac pathology should be consulted for details, the outstanding feature is a large heart in the absence of hypertension or valvulation. Large heart. The victims are usually young adult, partially become because in older groups in which there is atherosclerotic coronary disease and also hypertension. This overlay the cardiomyopathy and make the diagnosis difficult or impossible. Only exception is that there is definite histological evidence or if the heart weight is excessive 700 gram in the absence of a valve defect. Cardiomyopathies are the most common cause of heart failure and are an important cause of death in children and adults. According to the report of the 1995 WHO International Society and Federation of Cardiology Task Force on the definition and classification of cardiomyopathy, they are classified into the following main types: dilated, hypertrophic, restrictive, and arrhythmogenic right ventricular cardiomyopathy. Dilated cardiomyopathy is the most common cause of congestive heart failure. The annual incidence varies depending upon the diagnostic criteria from 2 to 8 cases per 10,000 or 1 lakh. Around 30 to 40% of them are familiar, but it also idiopathic, viral, immune, or toxic, alcoholic. Idiopathic dilated cardiomyopathy is characterized by dilated ventricular chamber, reduced the contractility without coronary, valvular, and pericardial disease. Histology is non-specific. However, viral genome has been identified in 10 to 34% of patients with dilated cardiomyopathy. Hypertrophic obstructive cardiomyopathy was first described in medico-legal autopsy material by London forensic pathologist Donald Tier in 1958. Although he noted and described asymmetrical hypertrophy of the interventricular septum so that a bulging part of myocardium partially obstructed to the left ventricular outflow tract. This cardiomyopathy is predominantly 75% non-obstructive disease. Hence, hypertrophic cardiomyopathy is now the preferred name. It is a primary sarcomere disorder characterized by left or right ventricular hypertrophy and is most cases inherited as a predominantly autosomal disease. It is caused by mutation of any of the genes encoding the proteins of the cardiac sarcomere. Between 20 to 30% are familiar, and the condition may occur at any age from infancy to salinity, though the majority of death occur in early middle age. Weight of the heart may range from a high normal at 400 gram to 800 gram or even 1 kilogram. More striking than the total weight is the left ventricular preponderance, which is often maximum in the proximal segment as described above. Histologically, the myocardium shows irregular sized large fibers with a nuclear pleomorphism. Though once thought to be a rhabdomyoma or a hamartoma or aberrant adrenergic tissue, the septal bulge usually shows a bizarre pattern of fibers with a loss of orderly strata and replacement by a crisscrossing confused architect of muscle bundles. Interstitial fibrosis is common, and though there may be an increase in interstitial cellularity, inflammatory infiltrate is not seen, as it would be an active myocarditis. Restrictive cardiomyopathy is, according to the WHO report, characterized by restrictive filling, reduced diastolic volume of either or both ventricle, with a normal or a near normal systolic function and wall thickness. Increased interstitial fibrosis may be present. It is idiopathic or associated with other diseases such as cardiac amyloidosis, cardiac hemochromatosis, or endocardial fibroelastosis with or without hypereosinophilia. Arrhythmogenic right ventricular cardiomyopathy. ARVC is a primary Myocardial disorder characterized by progressive fibropathic degeneration of right ventricular myocardium. Arrhythmia and risk of sudden death. In addition to the familial autosomal dominant disease with variable penetrance and polymorphic phenotype, two autosomal recessive forms of arrhythmogenic right ventricular cardiomyopathy are known. WHO classification includes further two groups of cardiomyopathy. Specific cardiomyopathy that are associated with a specific cardiac or systemic ischemic valvular hypertensive inflammatory metabolic general systemic connective tissue or neuromuscular disorders. Unclassified cardiomyopathy which do not fit readily in any group. Fibroelastosis or isolated non-compaction of the ventricular myocardium are rare disorder characterized by excessively prominent trabecular meshwork, ventricular arrhythmia, and systemic embolism. Thank you.